Welcome, everyone, to the National Fellow Online Lecture Series sponsored by the Fellows Online Education Subcommittee, the Education and Fellowship Committees. Tonight, we're excited to welcome Dr. Jeremiah Ray, who's going to be talking on peripheral nerve blocks and nerve entrapments. Just a few housekeeping items before we get started. We always want to mention the goals of the National Fellow Online Lecture Series, which are to provide an adjunct to the home program's educational content, provide fellows with direct access to educational experiences with AMSSM members, and at times invited experts. We also want to assist in CAQ exam preparation, so this is very much focused on this subject matter. A reminder to mute your device's microphone, turn off your video, submit questions through the chat function as the speaker is talking today. I'm going to be moderating sessions at the end with a Q&A session, and please complete the evaluation at the end of the lecture today. Lastly, one of our new efforts is to facilitate more input from our audience. There are a couple ways you can do this. First, we have a web link that can be found by going to amsssm.org. Click the Education tab and then select Fellow Online Lecture Series. The link is near the top of the page as seen in the screenshot. There's also a QR code, so I'll give you a second if you want to scan this. And when filling out the form, we ask that you please keep in mind the primary goal of this series is to assist in CAQ preparation for fellows. We would also like to promote the AMSSM Library of Sports Ultrasound Pathology. This is a collection of sports ultrasound pathologies published on the AMSSM website. Any attending or trainee can submit cases. All pathologies are welcome and these publications can be added to your CV. Scan the QR code or go to the website listed here to explore cases and learn more. And just to give you a quick sneak peek, in 2 weeks is going to be our next session. This is going to be an ocular injury, so Wednesday, September 2nd at 8:30 p.m. Eastern Standard Time, and our speaker is going to be Dr. Yusuf Khalifa. So on to our session today. Dr. Jeremiah Ray is a board-certified emergency medicine and sports medicine physician who completed an additional fellowship in musculoskeletal ultrasound. He earned his undergraduate degree in biochemistry from Occidental College, where he graduated with honors, was a 4-year NCAA soccer athlete, and also spent time competing as a professional snowboarder. He received his medical degree from Stanford University School of Medicine, completed emergency medicine residency and ultrasound fellowship at the University of Utah, and returned to Stanford for fellowship training in sports medicine. Dr. Ray currently practices with Hoag Medical Group in Southern California and previously served as a team physician for the Los Angeles Chargers. In 2024, he transitioned from the NFL to become Chief Medical Officer for the USA Olympic Surfing Program, and he also serves as team physician for USA Volleyball, the Orange County Soccer Club, and as a physician for the World Surf League North American Tour. Outside of medicine, Dr. Ray enjoys surfing with his wife and 4 children at Donny Beach in Dana Point, California. Without further ado.
Okay, very cool. I have 4 kids, and tomorrow's the first day of school, so there's a lot of excitement happening. So if some kids crash in here, don't be alarmed. We'll just keep moving along here. So I have no disclosures today, and just so you know, the background is hideous. I hijacked one of my presentations from the 2022 AMSSM National Conference, and just kind of rolled with it. My wife gave me a lot of grief about how ugly that is, so I apologize on that one. Today we're going to talk about nerve blocks. Why do we do nerve blocks? I'm going to give you the basics and very high yield input on how to do those blocks. I'm going to give you my favorite blocks that I do on a regular basis. My practice is predominantly procedural. Over the last 2 years, I'm about 50% procedural as far as my clinical encounters. So I end up doing a lot of blocks. And then I don't think we're going to have time for nerve entrapments, but if we do have a little time at the end, I can talk about some nerve entrapments as well. First question, why do we do blocks? It's because we do some stuff that hurts, right? So when we're using these big needles, these 20 gauge needles to either do a tenotomy, a calcific barbotage, PRP, we're working through some very sensitive tissues with neovascularization and kind of increased sensitization. Those tendons are really, really sensitive. So most of the time, if you're not doing a block, you're going to have some pain. So these can be really useful. This is a little bit of a side quest, but a relevant side quest. This is a table looking at PRP for tendon issues versus just a needle tenotomy. But what I want to highlight here is either way, with a PRP or a tenotomy or a PRP with a tenotomy, you're poking some really sensitive tissues. Here's a table looking at some needle sizes, and you guys all remember in physics that the flow resistance is related to the radius of the lumen to the fourth power. That's kind of how I think of pain with needles as well. So that when you get these bigger needles, these lower gauge needles, it hurts a lot more. And so when you're sweeping these big 20 gauge needles through tissue, it's a sensitive ouchie. So just want to be mindful of what we're doing to our patients. So I'm going to move into kind of the basic highlights of how to block and what to do. In most of our clinics, we have basically three local anesthetics, I think, that are the most common ones: lidocaine, bupivacaine, and ropivacaine. For clinical blocks, what we're going to be doing, because we're not doing general anesthesia, we're not trying to get post-operative pain management. We're commonly going to be using something that has a fast onset so we can get on with our procedure. So my workhorse is going to be lidocaine. I use 1% plain, and I use it without, well, plain is without epinephrine. So usually within several minutes, you'll start to get some onset of block. I like to give it a good 10-15 minutes to let that block get nice and dense. So I'll go into the procedure suite, I'll perform the block, and then I'll go and see my next patient. And then I'll come back once that block is nice and dense and get to work. First, First little tip here is no air. So there is a great way to ruin your ultrasound image and see what you're doing, and that is to introduce air into the tissue. So whether you're doing a procedure or doing a nerve block, it doesn't matter. If you get any air whatsoever into that tissue, you're not going to be able to see anything. So I don't know if you can see my cursor, but on the right ultrasound image, you just have complete loss of far field because of the air disrupting your ultrasound interface there. And because I'm a dad, this is a perfect example for a dad joke here. Remember Finding Nemo? This is actually a character named Bubbles, and he goes, "My bubbles." So just keep the bubbles to bubbles and not in our ultrasound scan. Needle size is super important when you're using your blocks. When you're starting off, I would say, yes, go with a 22 gauge or maybe a 25 gauge. A couple of reasons. Number one, it's a rigid needle. So when you are doing your inline approach or out of plane approach, it's going to go where you point it, which is super important, particularly when you're getting used to this. It's so easy to visualize, and you can exactly see where that tip is, and you know where it is. The other thing is when you have these bigger needles, like a 22 gauge or even I wouldn't do a block with a 20 gauge, but these bigger needles, you can actually go to the nerve and you can actually push the nerve around. I wouldn't recommend it because they feel it. Whereas with smaller needles, you'll pierce the epineurium and actually go intraneural more easily. So there's a lot of advantages to the 22 gauge for the block. Personally, I always use the topical cold spray because if you're doing a painful block to reduce the pain, you're maybe doing a little bit of a disservice there. So try and make the block as less painful as possible. The final point here is to go longer than anticipated. So the worst thing that can happen is you're in your setup, you got your needle in there, and you just don't have enough distance to get the far field of the nerve. So always err on the side of a longer needle. Don't be afraid to bust out that 3.5 inch spinal needle. And if your clinic carries the 2 inch needles, those are really great workhorses for these. Now, 27 gauge, that's what I do. I've been doing this for a while. They're really hard to visualize. I swear it's like a single row of piezoelectric crystals on your ultrasound. So it is so easy. You move 1 millimeter and that needle is going to drop off of your visualization. The other thing is they bend and deflect. It's like a penalty kick. They're just like curving all around. So no joke, if you have a patient who flexes their muscles while that 27 gauges, you'll just watch the needle bend. There are plenty of times when I pull a 27 gauge out of a patient and it's just completely bent. So these are harder needles to work with because they're harder to aim. They can also pierce the epineurium a little bit easier, which is uncomfortable for the patient. Not really a long-term problem, but an uncomfortable problem. And then the other thing is if you're using a larger volume, let's say you're doing 20 cc's or 15 cc's, your thumb is going to get so tired. You're just going to be sitting there depressing that plunger, trying to get the fluid through a 27 gauge, and it can take a long time. But patients will then thank you for how kind of pain-free that experience was. It's really quite amazing how the difference between a 27 gauge and a 22 gauge is as far as the patient experience. But as far as starting off, go with a 22 gauge or a 25 gauge, be able to see that needle, have a more rigid needle, and get the injectate where you need it to go. The way that I start off my injections is I will always go deep to the nerve or my targeted area. And so there's a couple of reasons we do this. Number one, if for some reason you are unlucky at getting all of the air out of the syringe or out of the needle, and a little bit of air comes in, it'll mess up your far field that you're not worried about rather than messing up your view of the nerve that you're trying to inject. So the other reason is as you inject volume deep to the tissue, it'll actually elevate the target structure up into near field screen and make it easier to get at. And so there's a couple of reasons to start deep there. The goal of a nerve block is to get kind of a nice, good donut of local anesthetic around the nerve. That makes sure that you're going to get all of the different nerve fibers and you're going to have a pretty rapid onset nerve block. There's been a couple of studies looking at lower volumes and non-circumferential local anesthetic contact around the nerve, and it actually works, but you get a faster onset of a block and a denser block if you can get it all the way around. So for this nerve, I would come in onto the deep tissue in through here, inject all through the deep structures all the way around, and then I would come out, hit the top structures superficially, and get a nice circumferential donut of local anesthetic all around there. Now, lidocaine, which is what we're commonly using in clinic for procedural blocks, is really hard to overdose on. So even though you might not need a large volume to get a good donut wheel of anesthetic around these nerves, I usually recommend pulling up a lot more than you imagine. A couple of reasons. Number one, sometimes you get near the nerve and you'll be on the wrong side of fascia, and the fascia will deflect a lot of your anesthetic away from the nerve. And so it's way better to have extra fluid in your syringe and just have a little bit of extra just in case. And plus, if you put more fluid around there, you're just going to have a denser block and more rapid onset. So I'd say even though some of these blocks only need 3 or 4 milliliters, just pull up a 10 milliliter syringe and just have extras on hand there. The other part is it's so hard to get to a toxic level with lidocaine 1% plain. So I'll give you a visualization on that one. So if you have a 150 pound patient, that comes out to about 68 kilograms. If you look at the max dosing for infiltration of lidocaine 1% play, that ends up being 4.5 mg per kg. So the the max dosing for a 150-pound person in my clinic would be a little over 6 vials, 1, 2, 3, 4, 5, 6 of 5 milliliters of lidocaine 1% plain. So I mean, I've just never ever come to a circumstance where I've even been close to that. So don't worry about putting in extra lidocaine. Now, as an ER doctor, I will tell you, sometimes when you're working your nerves, you accidentally get vascular infiltration, and they will feel lightheaded, they will feel dizzy, and it's going to pass. I push IV lidocaine all the time in the ER as an antiarrhythmic, so don't worry about that too much, but just be aware that if within a few seconds to a few minutes, if they're feeling lightheaded, maybe a little dizzy, or they're having some palpitations, that's what it is. It'll pass within a few minutes. So I was going to pause here and take some questions about the basics and the mechanics of nerve blocks, but I guess, Sarah, we're probably going to save all of our questions until the end.
I think that would be ideal, but if anyone's
Oh,
got questions, I can interrupt through the chat.
okay. Perfect. Well, I guess I'll just keep moving on. Um, I'm going to break it down to the 6 blocks that I find to be the most useful in my sports medicine clinic. Um, Probably one of the more powerful blocks to learn how to do and learn how to do well is the suprascapular block because it's going to provide anesthesia to the supraspinatus rotator cuff tendon as well as the infraspinatus. And this is super useful because there's so much supraspinatus pathology, including tendinopathy, partial tears, as well as calcific tendonitis. And then also in adhesive capsulitis, there's just a lot of anterior capsule innervation that comes from the suprascapular nerve. So this is a really good one to use in those areas. When I'm looking at the common extensor complex, so tennis elbow or lateral epicondylitis, I like the radial nerve. One thing that's kind of funny about the radial nerve is I counsel patients that it gives them what I call T-Rex arms. So you kind of lose your wrist, hand, and finger extension. So if they're coming in midday or early in the day, you want to counsel them appropriately. Like, hey, if we do a nerve block, to the radial nerve, you're going to have T-Rex arms or one T-Rex arm. So if they're kind of like an IT guy or if they're an artist or if they're using their hands, they're not going to be able to go back to work. Suprascapular nerve block is not too much of a problem. You do lose some abduction, but you have so many other muscles that help with abduction. That one's not really a problem. It's kind of funky. You will lose external rotation with the suprascapular nerve block, but people don't commonly need forceful external rotation as a part of, daily living, so at least for an hour or two. Now, I've played around with the medial epicondyle a lot in the common flexor complex, and the ulnar nerve just doesn't get enough anesthesia to the flexor complex for work on the medial epicondyle. And so I've started incorporating the posterior branch of the medial antebrachial cutaneous nerve, and it's actually pretty easy because it's the same field of view. So you have your ulnar nerve and your median nerve kind of cruising down your medial aspect of your humerus here. And actually just anterior to the ulnar nerve is going to be the posterior branch of your medial antebrachial cutaneous nerve. And it's so easy to block that kind of in the same field of view. It is far enough. It is on the other side of the brachial vein, and I'll show you a picture of that where it does require a second poke, which is a little unfortunate, but you're not having to clean a new area or really move very far with your procedure setup. So that's nice. Now, patellar tendonitis, because when you're needling the tendon, when you're doing PRP to the tendon, calcific tendonitis, whatever patellar tendon work you're doing, I played around with all of the blocks on the patellar tendon, and there's just too much variable innervation. So I've tried the saphenous nerve, I've tried all four of the genicular nerves, and there's just too much accessory innervation coming from the vastus structures and higher up nerves. And if you really want to get a good dense block for patellar tendon work, which can be really spicy, it's got to be a femoral nerve block. Downside of the femoral nerve block is obviously they're not walking out of clinic, right? So they're on crutches, and they're also not driving if that's their right leg as well. So a lot of counseling needs to go into kind of the procedure day and what that looks like if you're going to do a femoral nerve block. On the Achilles tendon, also that thing can be pretty sensitive and pretty spicy, especially in the big, thick endodematous mid-substance Achilles tendonitis. So if you're doing tenotomy or PRPing through there, ooh, it can be pretty spicy. So I like the sural nerve block. Nice thing about sural nerve is it's just sensory only, so you don't need to put them in a boot or anything. Now, for the Achilles tendonitis work that you're doing, you're probably going to put them in a boot, but you won't have any motor blockade from the sural nerve, which is nice. Finally, I want to talk about the tibial nerve block, and this has just been a game changer. I offer the tibial nerve block even when I'm doing a simple cortisone injection to the plantar fascia. I mean, just it's such a sensitive area, and just the feet are so sensitive, and then you're going into a more sensitive tissue. Tibial nerve block really, really helps with plantar fascia work for sure. So here's kind of going in through each of the blocks one by one, some of the indications and how to perform it and some of the anatomy through each of the six blocks here. So I would say probably for me, I do, gosh, maybe a calcific tendonitis, calcific barbotage, gosh, maybe every other day, every third day. And if you don't do a suprascapular nerve block, these are just so sensitive, man, just all the tissue around the calcium deposits, so, so sensitive. And even if you're doing some local infiltration of a local anesthetic, you just can't really get good anesthesia on these ones. So I like the suprascapular nerve on this one. Here's an MRI. You see T2 weighted edema throughout the distal aspect of the supraspinatus. So this is going to be your good old rotator cuff arthropathy or good old supraspinatus tendonitis. And then here on this final image here, you see the classic T2 edema in the rotator interval that you see with adhesive capsulitis or frozen shoulder. And so this, when I'm doing my frozen shoulder work, I like the suprascapular nerve block as well. This is a fun one to do. It takes a little bit of practice to get it right, and actually, you can just pull up a lot more fluid and give yourself a lot more leeway on this one. I like to do. There's a couple of ways you can approach this, but my favorite way is to do an in plane approach, medial to lateral, and you're gonna just put your transducer just superior to the spinous process and through here. And then you're going to put your needle from medial to lateral in the supraspinatus fossa. You can do it over in the supraclavicular notch, but it's just easier in the fossa. I'll show you a picture here. So I flipped that shoulder here to have everything pointing the same way here. So medial to lateral, you're going to be going through the trapezius, through the supraspinatus, and you can put on color Doppler and you can see the suprascapular artery. And the nice thing is if you're coming from medial to lateral, your needle tip will come to the nerve first, and the artery will be lateral of where you're injecting. Now you do have this fascial layer that's here, and basically, if you get your needle anywhere into that fascia and inject, it's going to give you a nerve block, which is nice. So this is one where technically you probably could get by with like 2 cc's of precision guided local anesthetic, but I'll pull up 10 cc's. And sometimes based on their body habitus and kind of their adipose content, it can sometimes be a little challenging to see exactly what you're doing. And it's better to err on the side of more local anesthetic than less. No problems with that at all. Moving on to the radial nerve block. This has just been a game changer for all the calcific tendonitis to the tennis elbows to the lateral epicondyle and to all my PRPs here, which are usually pretty spicy. So this one, the radial nerve, you remember that gives you the Friday night palsy. And so the radial nerve travels down your spiral groove on the posterior aspect of your humerus. And then it comes anterior laterally there. And that's just an easy spot to get that radial nerve right as it's coming out. And like I said, this will give you the T-Rex arms. And so you're going to lose a lot of wrist, hand, finger extension on this one. But it's such an easy block. You can probably get by even as a beginner with a 27 gauge 1.5 inch needle because it's so superficial. It's hard to have a ton of adipose tissue to disrupt your images here. But again, you're going to want to come in, make sure you hit it deep, let that nerve kind of float up into your screen and then get a nice circumferential. For these blocks, you can usually get a nice wheel around it with as little as 4 cc's. But again, just pull up 10 cc's in your syringe, make sure that fascia doesn't redirect your local anesthetic, and you'll get a nice block there. So kind of the opposite side of the elbow, so the medial epicondyle. And just so point of reference, an easy way to figure out which side is lateral and which side is medial is your radius bone is always going to be on your thumb. And so that's always going to be your tennis elbow. So you see the radius bone lateral and then no radius, that's going to be medial. And so here medially, I played around with this one for a while and tried ulnar nerve blocks, and it just was kind of variable anesthesia, incomplete anesthesia. So I'll show you a nice little view where you can hit the posterior branch of the medial antebrachial cutaneous nerve at the same time. And it's pretty straightforward. So I like to go kind of like mid biceps area, maybe like just a little distally. And you're going to see ulnar nerve, you'll see the brachial vein. And just on the other side of the brachial vein, you're going to see the medial antebrachial cutaneous nerve. And so you'll come in, block the ulnar nerve, and I'd probably save a nice 5 cc's there. Now, sometimes you can go very superficial and just go on top of the brachial vein, but I find that it's just easier to slide your transducer a little bit more anteriorly, hit that nerve with a second poke, and then it's just easier to get a nice circumferential block there. Now, I've played around with these darn patellar tendon blocks for years, and the innervation is so variable. I've had wild raging success with genicular blocks on some people, but not on others. I've had amazing success with saphenous nerve blocks on some people, but not others. There's just a lot of variability, and so I'm just real with the patient. I say, hey, we could do this super simple genicular nerve block. You'll have no motor deficit, but we might not have complete anesthesia. We could just knock out the femoral nerve, but then you're on crutches for 2 to 4 hours before your leg. I always say 2 to 4 hours. It's always gone within an hour or so, but I just want to make sure that they, have expectations that are a little bit worse off, and then they're a lot happier when they're walking faster. But for patellar tendon work, I just find I got to get the femoral nerve if you really want complete anesthesia on this one. And this one, you're way up in the crotch. I hate working in the crotch. It's a gross spot to work, but this is how you got to do it. It's in the inguinal crease. And remember in medical school, it's navel towards navel. So the first structure is going to be the nerve, which is nice. So as we're working laterally to medial, the first structure we're going to have is the nerve. One thing that can be kind of funny is if you see uh, two femoral arteries, so you get the bifurcation of the deep femoral artery and the superficial femoral artery. You're too inferior, so you're going to want to slide your transducer more cephalad in order to get to kind of this iliac crease area. And this is going to be your femoral nerve right in through here. So you're going to come in laterally through your iliopsoas, and again, you're going to hit it deep. Now, this nerve is pretty big, it's pretty broad, and it's pretty easy to direct your fascia, the fascia to direct your anesthetic in other ways. So on this one, I'll actually pull up a 20 cc syringe. And I'll commonly use a curvilinear transducer and a 3.5 inch spinal needle on this one. You can't use a 27 gauge spinal, right? That's too flimsy, but I do stock 25 gauge spinals. They do get bent and redirected a little bit, but they're still a lot more comfortable than a 22 gauge. So on this one, again, I'll go really deep. I'll have 20 cc's of local anesthetic in my syringe, and we'll start deep and get a nice circumferential block on that one. Downside, obviously, they're going to be crutching out of there, and they're not driving home, so they need to coordinate with a designated driver. I love the sural nerve. This one's great for Achilles tendon work. It's sensory only, so you don't need to worry about a boot for the block part of it. But if you're doing Achilles tendon work, you're definitely going to want to boot them up. So this is great for painful Achilles tendinopathy where you're either doing a tenotomy or a PRP or a 10X. And the sural nerve it runs just lateral to the Achilles tendon. It's such an easy block to do. I remember the sural nerve, if you go too high, it gets innervation from both the fibular nerve. I use the word fibular instead of perineal, because perineal sounds too much like perineum, which is a totally different geography. Don't mess that up. But you got your fibular nerve and your tibial nerve providing input here. So you want to make sure you're hitting it at least distal to the gastrocs for variable kind of neuroanatomy. So I usually like to hit it, gosh, like maybe 5 centimeters proximal to where the tendon work is going to happen. And you just find your Achilles tendon. You got your sural nerve is just so easy to get. It's quite superficial. And I'll come in either way. Like I don't do a whole lot of repositioning for this patient. I can either come in anteriorly or I can come in posteriorly. It doesn't really matter. But on this one, I'll even use a 27 gauge 1.5 inch needle. It's pretty small, but as you're starting, like I said, keep it with a bigger needle. Now the tibial nerve, this has just been a game changer for the plantar fascia, man. This is so good. I'll hit the tibial nerve just kind of like just north of the tarsal tunnel in here. It's really easy to get. So I just kind of scan up and down, and I'll just find a spot above all the different bifurcations and trifurcations of the tibial nerve where it's just really easy to access, where it looks easy. It doesn't matter if you go higher. The downside is if you go really low, you're getting a lot of branches and you might miss some important branches. So I'll usually hit it a couple of centimeters north of the calcaneus here, where it's nice and easy. And again, the mnemonic for their structures here is we got Tom, Dick, and very nervous Harry. So we got our tibialis, flexor digitorum, we got our very nervous, and then we have our hallucis and through there. So this one, again, I'll pull up 10 cc's and just get a nice circumferential block right around that tibial nerve. Give it a few minutes, and you can go to town on that plantar fascia. It's pretty good. Downside, obviously, is you're going to lose a lot of important toe, foot, plantar flexion. And so you're going to have to boot them up on that one as well. Now, this is all shared decision making. These are not necessary components. And actually, when I talk about some of the motor deficits, whether it's going to be T-Rex arms or you're not going to be able to externally rotate or the crutches, a lot of patients will actually say, you know what? I'm just going to go for some Tylenol and maybe some Tramadol, maybe a pre-procedure diazepam to help with some anxiety. And then we'll just do kind of local infiltration of local anesthetic. Usually people will choose the suprascapular nerve block because there's not a whole lot of downside. And when we're working on the Achilles tendon and on the plantar fascia, people will usually choose the tibial and sural nerve blocks. You know, the patellar tendon work, most people will choose either a trial of a saphenous nerve, and they'll get some anesthesia on that one and just say, I'll just tough it out for about 30 seconds or so. A lot of people decide not to do the femoral nerve block because it's so inconvenient. Unless they're like really scared and they have a lot of pain, then they'll choose that one. And so again, a lot of shared decision making here. And thank you all for your time. And I think that was exactly on time. So we'll open it up to questions.
This was great. I got a couple pointers here myself. So thank you for giving this talk, Dr. Ray. I am anticipating a few questions coming in. I do have one here. How long after you give the blocks are you typically waiting before doing your procedure?
Mhm. Yeah, so some people will have anesthesia within 30, 40 seconds, but usually that nice, good, dense anesthesia is going to take a little bit longer. So I'll commonly give them 10, 15 minutes to set in. So I'll do the block, I'll go see my next patient, and then come in for the procedure.
And then I imagine you're picking different medication options depending on how much motor weakness you're getting after the procedure.
Yeah. I see another question there. Let's see.
Yeah, so any downside to hitting the suprascapular nerve with a spinoglenoid notch instead of suprascapular notch?
No, none at all. I just find it's just kind of easier to hit it in the supraspinatus fossa. But if that's something that you're comfortable doing, you go for it. The only downside is just a little bit more technical. You have to have your angle just a little bit more spot on to hit it. But if you got that skill set, go for it. Ooh, do you have any good textbooks that describe these blocks step by step? I love NYSORA. Holy guacamole, New York School of Regional Anesthesia. So that's a great place. I've never paid for the subscription, although I use them so much, I feel like I ought to at this point. But they have amazing online modules. I like NYSORA a lot.
Got another question on using a posterior antebrachial cutaneous block for the common extensor tenotomy rather than full radial block. Thoughts on that?
Uh, no, I think it's just so much easier and you get so much more global anesthesia with the radial nerve. I just go with that one. Not really a whole lot of downside to hit the radial block.
How's your experience been with geniculate nerve blocks? Any
Yeah, it's
tips?
been so the genicular nerves, they give incomplete anesthesia to the anterior knee. You just get so many kind of escape nerves coming from the vastus medialis and vastus lateralis. Um, I was so pumped because my first couple of genicular nerve blocks for patellar tendon work were just awesome and totally successful. And then I had a tear of like 9 in a row where it was incomplete anesthesia. And so it's one of those things where I'll offer it to patients and just let them know it's quite variable. But now I don't do a lot of them anymore for the patellar tendon works.
And any thoughts on lidocaine versus ropivacaine in relation to cytotoxicity as well
I'm
as
ha
combining
yeah,
with
yeah.
PRP?
Happy that came up because that's actually the benefit of the block, right? Is because all of your local anesthetic is far away from where you're doing your tendon work. And so there's no contact whatsoever of the local anesthetic on the nerve block to where you're doing your tendon work with your PRP. And so that's actually the benefit, the primary driver of doing a nerve block when you're working with PRP.
And are you adding any steroid to prolong action of the blocks?
So when I'm doing tendon work, I almost never use steroid, right? What we're trying to do is we're trying to promote the machinery that's going to be helping with some of the remodeling of the tenocytes and the collagen laydown process. And so all of my tenotomies, all my PRPs, anytime I'm doing tendon work, it's going to be steroid free. Now there are a whole bunch of people who say, I'm going to play the short game. I want the Band-Aid. Let's just hit superficially over the painful tendon with steroid for now, right? But that's a completely different type of procedure than an actual like needle fenestration of the tendon tissue.
I know at one point that some folks had been using steroid like when actually doing the nerve blocks. Really see much value in it, but I don't know if you have any opinions on
You know,
that.
it's funny that you brought that up, Dr. Raiser. Actually, I don't know the name of the society, but the like American Anesthesia Pain Society actually just had a consensus statement come out like 4 days ago on the role of corticosteroids in peripheral nerve blocks. And they came down pretty hard against the use of steroids for the majority of cases. They still recommend it in a couple of cases like ilioinguinal, iliofemoral, iliogenital nerves. And there's a couple of, but they've like completely backed away from the use of corticosteroids, particularly on like the more common ones like median nerve for carpal tunnel syndrome. And so and they really hammer against the particulates, so like triamcinolone, for example. And so I think probably in 5 years, we're probably going to be shying away from a lot of the corticosteroids for our nerve blocks and chronic neuropathic pain and just kind of erring on the side of more of a hydrodissection with like a D5W type of solution.
All right, we got more questions rolling in here.
Right on.
How did you start incorporating nerve blocks into your clinic? What advice would you give to fellows or providers interested in pursuing a procedural-based practice?
Ooh, I guess yeah, so I was an ER doc first, and so we started learning ER we started learning blocks in my residency. And then I got really psyched about it when I started doing scaling blocks for shoulder dislocations and proximal humeral fracture reductions. And I just like it was magical. And I was just so like, okay, this is what we got to do. And so as far as how to learn it, I would probably sign up for the course. Like I think there are probably courses every year on ultrasound pre-conference, and so you can sign up for one-on-ones, and you can just have your teacher just show you all the different blocks.
And
And
go ahead.
oh yeah, and as I say, go to Nicora. That website is awesome.
Another question asking about kind of the things to treat tendons with. So, any thoughts on prolotherapy, with dextrose versus PRP versus needle tenotomy?
Mhm.
Um, needle tenotomy plus PRP. Do you have any experience with prolotherapy fenestration rather than PRP, especially in underserved population?
Yeah, so I do all of them. And there is some I guess in that first table I showed there's actually one tendinopathy study that showed tenotomy is equal to PRP plus tenotomy. And then there are a few that show some better patient pain scores with the tenotomy over PRP. But most of the data, and it is tendon specific, most of the data does favor a PRP with a tenotomy as the optimal way to heal oh nice. Andy's got the link to that consensus statement on steroids.
Awesome.
Um and so usually I'll say, hey, if you can swing the $1,200, let's do a PRP with the tenotomy. If you can't do it, I'll do a tenotomy, and I just bill their insurance as a tendon injection, right? And so I'm just billing a 20550. I'm getting massively underpaid, but it's the right thing for the patient, right? And then I'll just do a 22 modifier, so a unique or unusual procedure, and you get 10% more for your tendon injection with that. So I'll try that one. I usually counsel them that they'll get about 70% of what they get from a PRP with that one. And then the prolotherapy one, I don't have a lot of experience actually doing a tenotomy with injecting hypertonic dextrose solution or hyperosmolar dextrose solution within the tendon. I've done those more intra-articularly and then more kind of peritendinous. And I have some patients that love it. I would say my prolotherapy outcomes are pretty equal to placebo. So I would say maybe 20 to 30% of people are pleased with it.
All right. Well, I think the questions have slowed down. This was a great talk. Thank you so much for taking the time tonight, and fielding all these questions as well. Thank you for
Cool.
everyone who showed up tonight, for a late night for the folks on the East Coast. I hope everyone has a good night. Thanks, Dr. Ray.
Thanks. Bye-bye.